TMD examination. Where patients require a large number of restorations, we advise screening for underlying TMD as described in the book. We are going to show a more complete examination needed for patients, like this young woman, reporting pain and jaw problems. It is sometimes more convenient to arrange a further appointment to record a detailed history, examination and diagnosis. At her next visit, to save time, the patient is given a questionnaire to record pain intensity, general musculoskeletal problems and parafunctional habits. You can also screen for serious disorders, especially those of neurological or psychological origin. Where the patient indicates there are problems, you can ask about these in more detail. With TMD, it is useful to know whether the muscles, joints or both are affected. To help locate the origin of the pain, ask the patient to map out areas of discomfort.
Around here and going right the way to here and all the way down the side of my jaw.
If the patient finds this difficult, you can palpate the TMJ and muscles to determine the origin of tenderness. In order to standardize the amount of force applied during palpation, practice using kitchen scales to give a reading of 1 kilogram, and for sensitive areas described shortly, half a kilogram. Palpate the TMJs using half a kilogram. Here the right joint is tender laterally, but there is no tenderness from within the ear canals. Now feel for joint sounds such as clicking and crepitus during movement. Repeat opening and closing 3 times to ensure consistency and eliminate false findings. Then repeat jaw movements to the left and right 3 times, and forwards 3 times. There is a slight click of the right TMJ during 2 of the protrusive movements. Now palpate the muscles. Start with the neck, as trigger points in the neck can refer pain to the head and jaws. 4 areas are palpated. Firstly, sternomastoid. Secondly, the posterior intrinsic neck muscles. Thirdly, trapezius right up to its skull attachment. And finally, the shoulder muscles. Next, palpate the masticatory muscles. There are 8 sites extraorally and 2 intraorally. Start with temporalis, which is divided into anterior, middle and posterior regions. Ask the patient to clench lightly to show the muscle boundary and then to indicate where palpation is painful. Palpate the 3 regions using 1 kilogram. Here, only the right anterior temporalis is uncomfortable. Next, palpate masseter over its origin, body and insertion. Again, light clenching may be helpful to identify the muscle boundary. Here, both the body and insertion of right masseter are tender. Complete the extraoral palpation beneath the mandible and behind it. These areas are naturally more sensitive, so use half a kilogram. Now palpate the 2 intraoral sites using half a kilogram. Firstly, using your little or index finger over the lateral pterygoid region. This is up in the buccal sulcus, behind the maxillary tuberosity. This is where you need to position your finger. Next, palpate the temporalis insertion, just above where you place your thumb when giving an inferior dental block. Here the muscle is quite tender. This is where temporalis inserts into the coronoid process. We are interested in recording both the quality and quantity of jaw movement.
Try 2 now.
A quick way of checking for limitation is to use the patient's fingers. Normal opening is about 3 fingers width, but it is better to use a ruler. Before measuring, check on opening and closing for any deviations to the left or right. Gently retract the lip to see the lower midline. Again, repeat movements 3 times to ensure consistency. Now measure opening with a ruler, noting the reference teeth.
Okay, and now just open slowly, a bit wider, a bit wider.
Remember to add the overbite, in this case 4 millimeters.
Open as far as you
Always
can
ask the
comfortably.
patient, open as far as you can comfortably, and open as far as you can even though it
Open
hurts.
as far as you can, even though it's a bit uncomfortable.
Record the measurements and any areas of discomfort.
41, 46.
If opening is limited, see if gentle pressure will encourage it further. You will find the thresholds of limitation detailed in Chapter 7. Finally, measure mandibular excursions. Hold the ruler above the lower midline and ask the patient to slightly separate their teeth and move the lower jaw to the left
The middle. Separate slightly.
and then to the right.
To the right, as far as you
Note any limited movements less than 7 millimeters.
to the middle. Okay, that's good.
Measure protrusion by first recording the horizontal overlap,
3
3 millimeters, and then adding this to the amount protruded beyond the upper incisor,
Push it.
6 millimeters in all.
That's 4 millimeters. And back again. That's fine.
In summary, our patient has pain over the right TMJ, a slight protrusive click, 4 sites of masticatory muscle tenderness, and slight limitation of protrusion. Return to Chapter 7 to interpret these findings and come to a diagnosis. Accurate alginate impressions. Accurate impressions are critical for occlusal work and require rigid, fully extended trays. First, check all the teeth are included. Rim locks offer advantages over perforated trays. The rim retains the impression without adhesive and avoids distortions associated with perforations. Mixing is important. Spread the material against the bowl to give a uniform mix and reduce air bubbles. Smear alginate on the teeth whilst the tray is loaded. In this way we can avoid air blows on the occlusal surfaces. Seat the tray without delay. Once set, break the peripheral seal and snap the impression out. Trim with a scalpel and inspect the tray periphery to ensure the impression has not pulled away. Now for the lower impression. Use a mirror to pull extruded material back over the rear of the tray, which helps keep it in place on removal. Finally, trim and disinfect. We consider further the importance of accurate impressions in Chapters 1 and 8 of the book. Semi-adjustable and average value articulators. The two workhorse instruments of the restorative dentist are the average value and semi-adjustable articulators. Their diagnostic and treatment uses are outlined in Chapter 8. Our aim is to look at their components and adjustments. Let's begin by naming the parts of the semi-adjustable articulator. These are the upper and lower members. The lower member simulates the patient's mandible having two condylar elements set 110 mm apart, representing the average intercondylar distance. This is the incisal guide table, and these are the lugs and screw which hold the base plate for mounting the lower cast. When attaching the base plate, take care not to cross-thread the screw. We will attach the upper member using the centric latch. This holds the members together like a precision hinge. Engage the latch by pushing it down, and disengage by pressing against the release on the underside of the crossbeam. Now let's look at the slightly more complex upper member. From above we see the incisal pin, the screw for the upper mounting plate, and the two fossa elements. Underneath are the attachment for the centric latch and the guiding surfaces of the fossa elements. There are three surfaces which guide the condyle: the superior wall, medial wall, and posterior wall. The easiest adjustment to understand is the condylar guidance angle. You can see how the condylar ball runs down the slope of the superior wall in protrusion. Set the condylar guidance by adjusting the tilt of the superior wall and tighten. We usually leave it set at 25 degrees. To show the effect at tooth level of altering the condylar guidance, we have attached casts mounted in ICP. Look what happens if we increase the condylar guidance angle. In protrusion, the posterior teeth separate or disclude easily, whereas with a low angle disclusion disappears and teeth tend to rub. Therefore, we routinely use low angles of 25 to 30 degrees to produce restorations with low cusps and the potential to disclude. As well as protrusion, we need to consider lateral excursions. See how the right condyle moves straight forwards in protrusion. In left lateral excursion, the medial wall guides the orbiting condyle inwards and forwards, whilst on the working side the rotating condyle moves outwards and backwards along the distal wall. The progressive side shift adjustment is here. We have set it midway between 5 and 10 degrees. The immediate side shift adjustment allows the medial wall assembly to slide sideways. Normally we leave it set at 0, which keeps the articulator centred with the centric latch off. Now we will look at the average value articulator. Essentially, the lower member is the same as that of the semi-adjustable articulator. The condylar elements are spaced at 110 mm. There is a centric latch and guide table. The difference comes in the upper member, which has integrally moulded fossa elements. These have a condylar guidance angle of 25 degrees, progressive side shift of 7 degrees, and no immediate side shift. Therefore, condylar movements are the same as for the semi-adjustable articulator on standard settings. Being able to transfer casts between an articulator in the lab and one in the clinic is an extremely useful facility. This is possible with both types of DINAR articulator, with the articulators kept standardized using the manufacturer's field gauge and these adjustment screws. We consider articulators further in Chapter 8 of the book. Recording centric relation. To mount casts in centric relation, you need a centric relation record as well as a facebow transfer. We will be using bimanual manipulation to seat the condyles in centric relation, as we did during the occlusal examination. First, identify the retruded contact so that after mounting the casts, you can check for accuracy. If the jaw is stiff to manipulate, one of the techniques described in Chapter 8 can be used to help. Various jaw registration materials are available, but we have chosen Beauty Hard Wax for this demonstration. Generally, you need 2 layers of wax, although a single layer is better if there is only a small slide between RCP and ICP. If the patient's casts are to hand, indent the warm wax on the posterior teeth to facilitate trimming. The record should just overlap the posterior teeth. To help hold the record in place, cut a pair of tags in the canine or premolar regions. You don't need to include the anterior teeth if sufficient posterior teeth are present to provide stability of the casts when mounting. Warm the record evenly under warm water at 55 degrees centigrade. A hot tap can be used, but a water bath is best. Tell the patient that she will need to bite slowly into the wax, but must stop immediately when asked.
You can support that for me.
Now manipulate the mandible and start to close the patient into the wax.
A little bit more.
Tell her to stop when the incisor separation indicates the posterior teeth are just about to contact.
Okay, hold it there.
Hold the jaw in this position for around 30 seconds and allow the wax to cool and harden. Then re-manipulate to check if the teeth hinge cleanly into the indentations. If not, the record must be repeated. Cool the record under cold water. Replace and double check that the position you have recorded is repeatable. These records are most accurate if they register only cusp tip indentations. Hold the record up to the light and see if the thinnest part corresponds to the retruded contact. If you feel the indentations are insufficient to locate the cast properly, enhance them by using fast-setting zinc oxide eugenol such as Temp Bond. Once satisfied, disinfect the record. Normally, Beauty Hard Wax provides accurate mountings, but as shown later, we were unhappy with the resulting RCP-ICP slide. As we were confident of our impressions and mounting procedure, we decided to re-register using a different technique. To help stabilise the mandible in centric relation and stop the patient posturing into ICP, we made a Lucia jig from self-cured acrylic. The jig is simply a platform against which the lower incisors contact. Make it just thick enough to prevent the posterior teeth contacting and remove it just before the setting exotherm. Trim to remove any indentations. Then ask the patient to slide to the right, to the left and forwards. These excursions are marked to give an arrowhead tracing. Refine the adjustment to narrow the tracks until the arrow point makes a stable centric relation contact against a single lower incisor. The jig supports the mandible, allowing registration with a less viscous material, in this case an addition silicone mousse that can be syringed occlusally or interocclusally and removed as a rigid registration in just over a minute. Return to Chapter 8 in the book to read more about centric relation. The Facebo record. The Facebo simply transfers to an articulator the relationship between the maxillary teeth and temporomandibular joints, enabling accurate mounting of an upper cast. This helps simulate the paths of movement at tooth level during opening, closing, and excursions. A Facebo record takes only a couple of minutes, but can save a lot of time. This is true whether mounting casts for diagnosis or for making restorations. The Diener Slidematic Facebo is an excellent design consisting of self-centering ear bow, a bite fork and a connection between the two called the transfer jig. We will now demonstrate the Facebo transfer on our patient. Begin with the reference point locator to mark a point a fixed distance above the upper right lateral incisor. This point helps align the Facebo to the horizontal. Now attach the transfer jig to the Facebo. Align the jig so that the numbers on the clamps are the correct way up and read 2, 1, then tighten. The spigot on the bite fork always faces to the patient's right side. Check the bite fork slides freely into clamp number 2. Register the bite fork against the upper teeth using either wax or a silicone registration material. We will use blue mousse as it sets rapidly. Apply to the bite fork on this side, not the side where the spigot is attached. Hold the fork steady while the material sets. Then ask the patient to hold the bite fork in place with her thumbs. In a coordinated movement, the Facebo is guided into place. The dentist guides the clamp while the nurse inserts the earpieces, pulling them inwards and forwards. Secure the calipers by tightening a single screw. Next, align the bow with the reference point by sliding over the indicator arm. Adjust the height of the arm by moving the rod through the clamp number 1 and then tighten. Before tightening the second clamp, pull the bow gently forwards. Check that both clamps are tight. Then loosen off the calipers and remove the assembled bow from the patient. Before sending the transfer jig to the lab, the bite fork needs to be washed. Then disinfect using an alcohol spray to avoid problems with corrosion. Also spray the Facebo ready for the next patient and replace the disposable earpieces. This is a good system as the Facebo is kept in the surgery while the transfer jig is sent to the lab. Here it is connected to the articulator, ready for the upper cast to be mounted. You can read more about Facebo records in Chapter 8 of the book. Mounting casts. We can now articulate the casts using the Facebo and centric relation records. Before mounting, check there are no blebs on the occlusal surfaces. These casts from another patient show several blebs needing trimming. A good impression technique will avoid trapping air and bleb production. Next, attach the mounting plate to the upper member of the articulator. Take care to align the plate with the location lugs to avoid cross-threading the screw. Before mounting, it is worth standardizing the fossa elements. Set the condylar guidance to 25 degrees, the progressive side shift midway between 5 to 10 degrees, and eliminate immediate side shift as follows. Simply engage the centric latch and adjust the medial walls of each fossa to contact the condylar balls. Now secure the transfer jig to the lower member of the articulator. Do this by removing the guide table and sliding on the mounting shoe, which is then tightened. Align the flat on the transfer jig with the hole in the mounting shoe and secure. Check the incisal pin is set to 0. If the mounting shoe is a plastic slider, make sure it supports the pin. Next, engage the centric latch to ensure the articulator opens and closes on a fixed axis. Stabilize the bite fork during mounting with a support jig attached to the lower member. You can now see the relationship of the upper cast to the condylar elements and the horizontal plane. Score grooves into the base to help relocate it should it become detached. Wet to promote adhesion to the mounting plaster. Use anti-expansion Artex stone for mounting with 30 ml of water and 100 grams of stone. Mix to a whipped cream consistency and apply to the cast and the mounting plate. Then close the articulator. Remove excess plaster and sculpt the mounting into shape. Once sufficiently hard, remove the mounting and finish to a smooth surface. Reattach the upper cast ready for the lower cast to be mounted. Now detach the transfer jig and bite fork support. Then place the lower mounting plate and incisal table. If mounting in the intercuspal position, the incisal pin is set at 0. However, we are mounting in centric relation, so open the pin by 2 mm to compensate for the thickness of the record. Position the record and the lower cast. Secure if not completely stable with sticky wax or plaster. Again, plaster the cast base and mounting plate. Close the articulator and sculpt the excess. Be sure to wait until the plaster is fully set before removing for any final finishing. Remove the jaw registration and the casts are ready for occlusal analysis as shown in the next video. Trial occlusal adjustment. Our patient who feels her bite changed following pregnancy is to have an occlusal adjustment to eliminate deflective contacts and interferences. The occlusal analysis suggests that this will be moderately difficult, so before carrying it out for real, we need to do a trial adjustment with mounted casts. We prefer to do this trial either at or immediately before the appointment to make it easy to remember where to adjust and how much to take off. To gain informed consent, tell your patient what is involved and about potential adverse effects, which are discussed in Chapter 8 of the book. The trial adjustment is done with a large flame-shaped diamond, the same instrument as used clinically. We also use composite finishing diamonds to smooth the rough surfaces and for fine adjustments. Start by lifting the incisal pin and disengaging the centric latch before marking the slide from RCP to ICP with red articulating foil. Next, remove the upper cast so the intercuspal contacts can be marked clearly in black. Tip the cast slightly to introduce the foil. This helps locate the correct position whilst each area is marked. Here are the black ICP contacts. We normally try to maintain these following the adjustment. The 2 red marks are the retruded contacts, and we will be adjusting these first. Reattach the upper cast and locate ICP. Now drop the incisal pin onto the guide table. This sets the intended vertical dimension at the end of our adjustment. Now engage a centric latch to see how far the retruded contacts lift the pin off the table. Begin by adjusting the retruded contacts on the upper left premolars. Remark the retruded contacts, which will now have changed, so examine both sides. Some contact remains on the upper left premolars, but now the upper right first premolar is also in contact. Again, adjust the inclined planes involved in the slide. Look at the incisal pin where the gap has reduced by about half. Continue to mark the deflective contacts. Now the contacts lie here, here, and here. We are confining our adjustments to the upper teeth, but it is good practice to share the adjustments with the lowers where it is more extensive. The pin is slowly getting closer to the table, but we still have a way to go. Continue to mark up, identify deflective contacts, and adjust until the slide is eliminated. This happens when the pin finally touches the table. Now lift the guide pin and check for even contacts using shim stock. There should be firm contacts posteriorly, which there are on the left, but here on the right the shim pulls through without resistance. Mark up the left side to locate the premature contacts, which you can see on the first molar and 2 premolars. Carefully adjust to avoid an unwanted loss of vertical dimension. Now all the posterior teeth should hold shim firmly. Next we're going to check lateral excursions, which we mark in red. Here you can see the non-working side interference we found intraorally. This is adjusted taking into account its mesiolingual direction and, if possible, keeping the holding contact. We have effectively created a groove through which the lower tooth can escape. Diagonally opposite is the upper left canine, which now guides left lateral excursion. In right lateral excursion, we can see there are no non-working side interferences and the guidance is clearly on the upper right canine. Finally, hold the articulator in both hands to feel for smoothness of all excursions and refine your adjustment if necessary. You can read more about occlusal adjustment in Chapter 8 of the book. Occlusal adjustment. If you are happy with the trial adjustment and your patient has given consent, you can start the adjustment proper. Mark up the retruded contact and slide between intercuspal and retruded contact positions. As this patient slides, you can feel her jaw shifting both forwards and to the right. Use black articulating foil to differentiate the intercuspal contacts. Now the sliding contacts show clearly in red. A good operator will anticipate the cusp slopes involved. Here we expect to see marks on both mesial and lingual facing slopes of the upper left premolars. Start to eliminate the deflective contacts, bearing in mind the order and amount of adjustment from the trial casts. If the water spray is switched off, take care not to cause overheating. Continue to mark up and adjust until the slide is eliminated. This means following the slide from tooth to tooth, which requires both care and patience. In some patients, this takes only a few minutes, but here many teeth are involved and the process took 40 minutes. At this stage, the patient should feel even contact when closed around her retruded arc. Notice that the contacts are small and discrete, rather than broad and rubbing. Check for evenness of contact using shim stock and adjust any heavy areas. Now we can refine the excursions. The trial adjustment suggests canine guidance is achievable bilaterally once interferences are eliminated. Starting with left lateral excursion, first identify any non-working side interferences. Here are the non-working side interferences we found on the articulated casts. Before adjusting any non-working side interference, double check that there will be a suitable contact on the working side to pick up the guidance. As this is not an issue, we can adjust the non-working side interferences. Next, check the working side for interferences, especially any heavy pivoting contacts posteriorly. There is potential here for canine guidance, but a number of posterior teeth are interfering. Carefully remove these interferences so that the canines are no longer lifted out by pivoting contacts posteriorly. Once satisfied with the left lateral excursion, repeat these procedures for right lateral and protrusive excursions. The adjusted tooth surfaces can now be smoothed with a composite finishing burr. Following the adjustment, you can see the red guidance slopes and the small, refined holding contacts in black. A similar appearance is evident in the lower arch. Finally, we sit the patient up and check for evenness of contact. Patients often adopt a slightly different jaw posture in the upright position, resulting in unexpected heavy contacts.
Right there.
About there, right.
Any adjustment
Okay,
at this
that's
stage
right.
should be minor, using a composite finishing diamond. Finally, make a follow-up appointment.
Hello Tracy, can you tell me how you've been since last time?
Great, everything's slowly settled in, the roughness is slowly smoothing out.
Yes.
Felt like I had brand new teeth the first weekend. The slide's gone completely. I've got a slight eye spot somewhere, it's absolutely minute on the right hand side about there.
Yeah.
But everything's great now, it's settled right in. Great.
Okay, so no jaw aches or
No,
headaches or anything
nothing,
like that?
Nothing like
Okay,
that.
and the slide's gone and the roughness is smoothing,
Yeah.
but you're left with a feeling of a little high spot on the right.
Tiny amount. to the
Can you point to exactly where it is?
It's around
Somewhere up there, but
possibly there, but it's very hard to really
Difficult
pinpoint
to
now.
tell,
It's
okay.
so minute.
Very good. What we're going to do is to mark up the contact and then see if we can find out where this little high spot is, and if possible just adjust it for you.
Okay.
Always schedule a follow-up visit a few weeks after the adjustment. Sometimes occlusal contacts change due to minor alterations in jaw or tooth position. Here you can see the slide to the right has crept back in. Mark up to show the slide in red and intercuspal contacts in black. The deflective contacts are here on the upper right first premolar and first molar. We also need to check the excursive contacts. Again, mark in red and differentiate the intercuspal contacts in black.
Close, going to the right, back to the middle, to the left, back to the middle, so close again, slide straight forwards, back, okay, open, firm tap, on the left, firm tap, and across the front, firm tap.
Let's look at the red contacts on the left side. You can see the canine is involved in guiding left lateral excursion, but there are also unwanted excursive contacts on the first and second premolars as well as the first molar. On the right side we also have canine guidance and a similar pattern of unwanted excursive contacts. Additionally, some of the black intercuspal contacts have a broad rubbing appearance. Having identified the problems, we can refine the adjustment. First, adjust the deflective contacts on the upper right first premolar and molar. Next, we will refine the intercuspal contacts on the left side and remove the excursive contacts on the premolars and first molar. Recheck for any deflections using bimanual manipulation. Clearly, there's a bit more work to be done. Remark the contacts and refine the cuspal inclines. Remember to smooth the adjusted areas with a composite finishing burr. Keep checking and eliminate any residual slide or interference. Finally, check for heavy contacts with the patient sitting upright. Before dismissing the patient, consider the need for further appointments to refine the adjustment. Remind the patient to get in contact if there are any problems. Occlusal analysis with mounted casts. Casts mounted in centric relation usefully supplement the clinical occlusal examination, revealing the character of the retruded contact and the slide into ICP. We will be using this information later to help plan an occlusal adjustment. First, check mounting accuracy. Hold the articulator in both hands and ensure that the casts hinge directly into the record without any slide or deflection. Look at the condyle and fossa elements, checking that the condyles remain fully seated. Now remove the registration. Lift the incisal pin. Release the centric latch. Confirm the retruded contact with shim stock. This should be against the patient's upper left second premolar. Next, slide the casts into ICP, taking care not to abrade them. If the retruded contact and slide into ICP do not reproduce what you found clinically, there is no option but to remount. Remember that your mounting results from a sequence of clinical and laboratory procedures, including impressions, jaw registration, and articulation. Even in experienced hands, mountings occasionally go wrong. Unfortunately, although our RCP contact was correct, the lateral component of slide was indistinct. As we were confident of our impression and mounting accuracy, it suggested the centric relation jaw record was at fault. Therefore, we re-registered using a Lucia jig and silicone mousse, and remounted the lower cast using the trimmed records to ensure proper seating. Success. You should be able to feel the slide as well as observing it in the incisor region and at the condyles. Here the left condyle moves forward slightly as the mandible slides to the right. The retruded contact can be verified with shim stock and the slide marked with articulating foil. We have correctly identified the deflective contact on the upper left premolars and the corresponding contacts on the lower premolars. You can also examine for excursive interferences, but this is not quite so reliable. Let's look at the left lateral excursion, which shows the guidance being lifted off the canine by the first premolar. We will look at these excursions in more detail during the trial occlusal adjustment. In summary, our analysis checks out with the occlusal examination where the slide was to the right, and, coupled with the patient's history, suggests a mandibular misalignment. If our patient had symptoms of TMD, we would prescribe an occlusal splint. However, she did not, and so in the next sequence we show how the articulator helped with planning the adjustment. Occlusal examination. If your patient reports any occlusally related problems or where restorative work is planned, it is wise to perform an occlusal examination. Our patient feels that her teeth do not meet properly, but the cause is unusual. She noticed whilst pregnant 16 months ago that all her teeth became mobile and, after the baby was born, did not mesh together comfortably. She is aware of her teeth hitting and sliding and of small chips of enamel coming from her front teeth. The instruments used for occlusal examination are comparatively simple. As well as a routine examination kit, you need Miller's forceps to hold red and black articulating foil and a pair of mosquito forceps to hold shim stock. The Willis gauge is needed only where you suspect a loss of occlusal vertical dimension. Screen first for underlying TMD by palpating the TMJs and the jaw muscles. Check also for limitation of opening. Here no problems are found. Examining the occlusion is not difficult, but it can be confusing to dentists not familiar with jaw movements. The simplest way to think about things is to remember that the teeth meet in the intercuspal position. From here, the mandible is usually able to go backwards into the retruded contact position, forwards into protrusion, and sideways into lateral excursions. Before looking at the teeth in occlusion, always check the arches individually. Look for over-erupted teeth, as with this upper left wisdom tooth. Sometimes they produce major occlusal interferences, but this one is far too distal to be a problem. Look also for signs of heavy occlusal loading, for example wear facets, vertical fracture lines, or tooth mobility not simply explained by periodontal disease. Now look at the teeth in the intercuspal position. Assess the amount of support posteriorly and the occlusal relationship of the anterior teeth. This Class 1 incisor relationship provides good capacity for anterior guidance. Dry the teeth with air before marking up with black articulating paper. Ask the patient, give your back teeth a single firm tap together. Look at the character and distribution of the intercuspal contacts. Here the posterior teeth have several broad rubbing contacts, suggesting they might interfere with jaw movement. Use shim stock to record contacting pairs of teeth. This is especially useful where the occlusion is uneven. Now we're going to guide the jaw back into centric relation so that the condyles are in their most superior position within the glenoid fossae. This technique is called bimanual manipulation. Notice how the fingers support the underside of the mandible and the thumbs guide the chin downwards and backwards, helping to peel back the lower lip to see the teeth. When manipulating, try and coax the jaw backwards as the patient opens. Use small, randomly timed arcing movements. These need to be made close to the position of tooth contact, but avoid bashing the teeth together, otherwise the patient will tense up and posture forwards. Gently rotate the mandible to close on the retruded contact. Then ask the patient to point to it. Repeat and ascertain whether it is in the same place. If the manipulation is difficult, read Chapter 8 for advice. Mark up the retruded contact and then ask the patient to squeeze together. The teeth will now slide from RCP into ICP. To distinguish the slide from the intercuspal contacts, use black occlusion foil and simply ask the patient to tap together. The retruded contact and slide are shown clearly as red marks against the contrasting black. Usually there is a single retruded contact, but here multiple teeth appear to be involved, with the strongest contact against the upper left 5. Interestingly, the over-erupted upper left 8 is not a deflective contact, although such teeth often are. If you look at the teeth from the side, you will see how far the jaw is displaced forwards by the RCP-ICP slide. If you look from the front, you can see if there is a lateral displacement, which in this case is to the right. We now need to examine the patient's excursive movements.
Back to the middle, to the right, back to the middle, and straight forward.
An interesting feature here is that the canines are lifted out of contact when the patient moves her jaw to the left. The facets on the canines show these teeth were previously involved in lateral excursion. This finding fits with the patient's story that her back teeth moved while she was pregnant, resulting in posterior interferences. Interferences are distinguished by the way they hamper or hinder smooth mandibular movement. Excursive contacts can now be marked with red articulating foil. First we will mark up the left lateral excursion. The foil is placed on the working side and the patient asked to move the lower jaw to the left. Again, use black occlusion foil to distinguish the excursive contacts from the holding contacts. Here the excursive contacts are not only on the upper left canine, but also on both premolars. There are no marks on the faceted tip of the upper left canine, confirming that it is being lifted out of contact. The canine provides guidance, but the heavier contacts on the premolars are interferences. The left lateral excursion is repeated, but this time the non-working side is marked up. Again, both red and black foils are used.
Firm tap together.
Here we see non-working side interferences on the upper right first and second molars. These pivoting contacts are also contributing to the unwanted separation of the left canines. Before examining the right lateral excursion, wipe off previous markings. The working side is now on the right and the non-working side on the left. Again record the excursive contacts. The upper right canine shows potential for guidance, but there is a heavier interfering contact on the premolar. Now check the non-working side, where we find no interferences. Finally, examine protrusion. Look to see if the posterior teeth disclude, or whether they guide or interfere with jaw movement, and then mark up. Here, protrusion is guided on the upper left lateral incisor and the 2 central incisors. The last thing to consider is the vertical dimension, which for our patient is not an issue.
Squeeze your teeth together.
Otherwise, it is a simple procedure to estimate the freeway space using a Willis gauge. Return to Chapter 8 in the book to read more about occlusal examination.
Cross-arch pivot and the non-working side interference. A similar problem to the last tooth in the arch syndrome occurs when a tooth with a non-working side contact or interference is prepared for a crown. Here you see how normally during a lateral excursion the teeth on the working side provide guidance, in this case canine guidance. Where there is a non-working side contact, this may act as a cross-arch pivot, resulting in either disclusion on the working side or distraction of the orbiting condyle, or both. Removal of the cross-arch pivot during tooth preparation obviates the need for the condyle to move away from the articular eminence. The resulting shallower trajectory of tooth movement on the non-working side leaves little or no space for the crown, although there is sufficient space in ICP. When the new crown is fitted, patients may well complain of symptoms associated with an interference. Adjustment is frustrating, with a high chance of perforation. Intercuspal position. When the maxillary and mandibular teeth meet in a state of maximum interdigitation, the mandible is said to be in the intercuspal position, or ICP. Ideally, this position is stable and reproducible. Lateral excursion into ICP showing disclusion. When considering lateral excursions, the arch is sagittally divided into 2 zones. The side the mandible moves towards is termed the working side. In this illustration, the side indicated by the yellow sphere. And the side the mandible moves away from is the non-working side, indicated by the blue sphere. Movements occur between these excursions and the intercuspal position. Normally, guiding tooth contact occurs on the working side. Here, only the canines on the working side are in contact, and we call this canine guidance. All the teeth on the non-working side are separated or in disclusion. From the inferior view, the condylar movement can clearly be seen. As the mandible moves to the working side, the condyle on that side rotates within the glenoid fossa, whereas the condyle on the non-working side orbits in an arc around the working side condyle. We therefore refer to these as rotating and orbiting condyles. Group function. In lateral excursions, there are two main patterns of guiding tooth contact: canine guidance and group function. In canine guidance, as we've already seen, there is tooth contact solely between the canines on the working side. In group function, contact occurs between more than one pair of teeth on the working side. Ideally, for both canine guidance and group function, there is total disclusion on the non-working side. Tracks of posterior movement. As well as knowing how the anterior teeth move across each other, we also need to be aware of what happens posteriorly. This knowledge will help with carving perfect plastic restorations and carrying out occlusal adjustments. It's easiest to think about these movements as viewed occlusally. We will follow the excursive movements of the mid-buccal cusp of the lower first molar, represented by the yellow sphere, across the occlusal surface of the maxillary first molar. By tracing these movements, protrusion, working side, non-working side excursions, a crow's foot pattern is traced out. In protrusion, the mid-buccal cusp of the lower molar moves anteriorly across the occlusal surface of the upper molar. In the working side lateral excursion, the mid-buccal cusp escapes between the mesiobuccal and the distobuccal cusps of the upper molar. In the non-working side excursion, the lower cusp moves obliquely over the mesiopalatal cusp. The asymmetry of the pattern of movement is due to the movement of the condyles in their rotating and orbiting functions. In this illustration, we follow the movement of the lower right first molar with respect to the mesiopalatal cusp of the upper first molar, represented by the yellow sphere. By tracing these movements, protrusion, working side, non-working side excursions, a crow's foot pattern is again traced out. With these mandibular movements, it's easiest to think of the upper cusp acting like a stationary pen while the paper moves. In protrusion, the upper cusps move distally across the lower molar. In the working side excursion, the upper cusp escapes between the mesiolingual and the distolingual cusps of the lower molar. In the non-working side excursion, the upper cusp escapes between the mid-buccal and the distobuccal cusps of the lower molar. Crowning and anterior guidance. The upper right central incisor is to be prepared for a crown. To avoid problems, you must bear in mind the guidance that the original tooth surface provides to the movement of the mandible. The aim here is to manufacture a final restoration that conforms to these present paths of movement. The red star indicates the point of contact between the incisors in intercuspal position, and its position should be preserved. The green line represents the original correct guidance path. This path dictates the contour of the final restoration shown by the yellow outline. In this illustration, we are restoring the tooth with a porcelain bonded to metal crown. The materials used to fabricate the crown need to be sufficiently thick to prevent fracture or perforation. The shape of the tooth preparation should be guided by this requirement without unnecessarily destroying tooth structure. let's look at the amount of space needed to accommodate the two materials. Firstly the porcelain, then the metal substructure. Outlined in red, we see the shape the preparation should be. The final crown maintains the original intercuspal contact and has not altered the path of movement in protrusive excursion. In this illustration, the minimum thickness of the crown has not been considered fully. Again, the intercuspal contact is shown as a red star. The preparation produces enough clearance at this point, but without considering the excursions. As the mandible moves anteriorly, it still follows the original path, shown in green. However, the technician has insufficient space to make the crown to this contour, resulting in a lingual surface that is over-contoured and bulky. The patient tries to adopt a new path of movement, shown in red, but as the lower incisor moves into a protrusive excursion, it attempts to follow the original correct contour. This applies a heavy, non-axial force to the newly crowned tooth. Such protrusive interference can lead to significant problems. Mobility, drifting, wear, and fracture of the restoration. Protrusive interference on crown. If the palatal contour on the crown is incorrect and too bulky, the interference can cause pain. Mobility, drifting, wear, and fracture of the restoration. RCP aspects, the ICP to RCP slide. In this illustration, we will consider the position of the condyles in different mandibular positions in an antero-posterior plane. Producing a sagittal section of the skull will allow us to view the dentition clearly from the lingual aspect. Centric relation occurs where the condyles are in their most superior position in the glenoid fossa. This is a position of musculoskeletal stability determined by the condyle-fossa relationship, not tooth contacts. For the purpose of clarity, we have not included the articular discs. The condyles here can rotate around the terminal hinge axis with an inter-incisor opening limited to approximately 20 to 25 millimeters. Further opening on a pure arc of rotation is prevented by various anatomical constraints. Closure in centric relation continues until the first tooth contact occurs. This defines a specific mandibular position called the retruded contact position, or RCP. Now the teeth slide from RCP, allowing the mandible to move anteriorly and superiorly into the intercuspal position, or ICP. In ICP, the teeth meet in a state of maximum interdigitation. Note how during the slide the condyle moves slightly anteriorly and inferiorly to accommodate the ICP mandibular relationship. Maintaining tooth contact, we show the mandible moves in protrusion, which causes the condyle to move down along the articular eminence, while the incisors guide the movement anteriorly. In certain situations, the retruded contact can become a damaging deflective contact. Occasionally, on closing to ICP, forward thrust of the mandible may occur, causing damage to the anterior teeth. This may result in wear, drifting, mobility, or damage to restorations. Identifying and carefully removing the deflective contact will allow the mandible to move posteriorly.